In the median nerve, in the median nerve, why we are starting our discussion from the humerus, lower end of the humerus? Because median nerve, it does not supply anything in the axilla or in the arm. And same for the ulnar nerve also. Median nerve and ulnar nerve, they are not supplying anything in the axilla or arm. So I start my discussion from the elbow only. Because the first muscle supplied by the median nerve is pronator teres. So injury to median nerve at the elbow or above the elbow. And same with the ulnar nerve. Ulnar nerve injury at the elbow or above the elbow, the features are exactly the same because nothing is supplied above the elbow here. So guys, median nerve root value is also the entire brachial plexus. It's a C5 to T1. C5 to T1. Median nerve actually leaves the cubital fossa by passing between the two heads of this muscle, and this time the muscle is pronator teres. The muscle is pronator teres. So median nerve will be seen passing between the two heads of the pronator teres muscle. The median nerve is the main nerve to supply the muscles of forearm. So what will happen? The main median nerve will take care of all the superficial flexors. All the superficial flexors of forearm, guys. Flexor digitorum superficialis, palmaris longus, flexor carpi radialis, whatever superficial flexors we have in the forearm, they are supplied by the the main median nerve, including FDS. Again, the muscle which needs to be highlighted here because this will help you in questions. FDS, flexor digitorum superficialis. Flexor digitorum superficialis. But we have some deep muscles also. So there are certain deep muscles in the anterior compartment of forearm, and all those deep muscles are mainly supplied by the median nerve. So what you see here in this picture, that there is a branch of the median nerve which is passing deep, and that's going deep because it is going to run in front of the interrocious membrane, and this nerve is called as the anterior interrocious nerve. Posterior interrocious nerve was the continuation of radial nerve. Anterior interrocious nerve merely is a branch of the median nerve, and this is basically going to supply the deep muscles, guys. And what are the deep muscles that we have? There are three deep muscles to be supplied by the anterior interrocious nerve, and all of them are important. I'll tell you why. One is flexor digitorum profundus, FDP. But guys, flexor digitorum profundus, it supplies only the lateral half. Flexor digitorum profundus is a hybrid muscle. Only the lateral half of flexor digitorum profundus is supplied by this nerve. Only the lateral half is supplied by this nerve here, flexor digitorum profundus, lateral half. Then flexor pollicis longus. Flexor pollicis longus, guys. Flexor pollicis longus is a long muscle which goes to the distal phalanx of thumb. It's a very long muscle which goes into the distal phalanx of thumb. So flexor pollicis longus is supplied by this, and one muscle is pronator quadratus. A small muscle, quadrangular muscle present. It's a very, very deep muscle of the forearm present only in this region, that is called as the pronator quadratus muscle. So three deep muscles are supplied by the anterior interrocious nerve. Flexor digitorum profundus, lateral half. It supplies flexor pollicis longus, and it also supplies one of the pronator, that is pronator quadratus. After that, what you see, guys, median nerve. Once the median nerve enters in the hand, it is passing deep to the flexor retinaculum. Right, that's a flexor retinaculum here, and you can see the nerve is passing deep to the flexor retinaculum from the carpal tunnel. But if you remember, a while ago only we discussed few structures passing superficial to retinaculum, and one of the nerve which is passing superficial to retinaculum is this, that is the palmar cutaneous branch. That's a palmar cutaneous branch, guys. Palmar cutaneous branch is passing superficial to the retinaculum. Once the median nerve comes into the hand, we know it is going to supply the thenar muscles. Thenars are supplied by the median nerve, guys. All the thenars are supplied to median nerve except which one? I hope you remember. Except adductor pollicis. Except adductor pollicis. So thenar muscles are supplied to median nerve except adductor pollicis. Except adductor pollicis. This nerve also supplies the lumbricals, the first lumbrical and second lumbrical. I hope you remember that also. The first and second lumbricals are also supplied by median nerve. In the hand, that's the contribution of median nerve. It supplies the thenar muscles except adductor pollicis, and it also supplies the first and second lumbrical. The unipinnate lumbricals are supplied by the median nerve. And then you can see there's another branch given here, guys. This branch here is called as a digital branch. That was a palmar cutaneous branch, and that's a digital branch. The difference is, The palmar cutaneous branch. The palmar cutaneous branch is basically going to supply the skin of the palm. Look at that color over there, the blue color. Only the palm, not the finger. Whereas the digital branch is going to supply the skin of the fingers, including nail beds. It supplies the skin of the fingers, including the nail beds here. And see why this difference is important. Because palmar cutaneous branch is passing superficial to retinaculum, whereas the digital branch is coming from the nerve which is coming deep to the retinaculum. So if there is a carpal tunnel syndrome, that means only digital branches will be affected, palmar cutaneous branches will be working. In case of carpal tunnel syndrome, guys, if the nerve is compressed here, so digital branch will be gone. That is gone. But the palmar cutaneous branches will be spared because they are passing superficial to retinaculum. So the carpal tunnel syndrome patients, they do not have sensory loss on the palm. They only have sensory loss on the fingers and on the nail bed. But on the palm, there will be no sensory loss because palmar cutaneous branch will be spared. It will be spared. It is passing superficial to retinaculum, so it will be spared. In the median nerve, see how we talk about that. There are three types of injury I need to look into the median nerve. The higher injury, which will be somewhere at the elbow or above the elbow. The lower injury is here, which is at the carpal tunnel, that is carpal tunnel syndrome. And there could be an isolated injury to the anterior interrocious nerve also. The injury to anterior, if only injuries to anterior interrocious, then what will be the features here? So look guys, let's call this as case A. If the injury is somewhere higher, that's called case A. If the injury is deep to the flexor retinaculum, let's call it case B, the carpal tunnel syndrome, that is case B there. And if the injury is to the anterior interrocious nerve, let's call it case C. So let's talk about the three cases here, A, B, C. Higher injury, lower injury, and the deep injury. Deep injury means to the anterior interrocious nerve. Now I want you to understand this one thing here very clearly, guys. If the if the median nerve is injured higher or lower, whether it is at the elbow, above the elbow, or it is at the retinaculum or in the forearm, now one thing is for sure, the thenar muscles definitely will be affected. Out of the three thenar muscles, abductor pollicis, flexor pollicis, and opponens pollicis, the three muscles which are supplied by the median nerve, opponens pollicis muscle is very unique here because there is no opponens pollicis longus or brevis. We just have a muscle called as opponens pollicis. That means we have just one muscle for the opposition of thumb. So if your median nerve is injured anywhere, that means your opponens pollicis muscle definitely will be gone. And if your opponens pollicis muscle is not working, then your thumb cannot oppose other fingers and thumb will be like this. So it is more like a ape thumb deformity. Your thumb cannot rotate for the opposition. Your thumb will be rotated in this manner, and that is called as a ape thumb deformity. So in median nerve injury, one thing is for sure, that whether it is a higher injury or lower injury, the patient definitely will have what deformity? Ape thumb deformity will be there because opposition of thumb is not possible in higher as well as lower injuries. Now let us say if I am your patient, I come to you with the ape thumb deformity. By looking at my ape thumb deformity, you can say it's a median nerve injury. Fine, no problem. But ape thumb deformity is not defining whether it is a higher injury or is it a lower injury of median nerve. So what are you going to do, guys? The first thing you will ask me, you will say, okay, make a fist. When you ask me to make a fist, I have to flex my fingers. Obviously, to make a fist, I have to flex my fingers here. And flexion of finger is done by these two muscles. Which two muscles? Flexor digitorum superficialis and flexor digitorum profundus. If the injury is higher, somewhere here, that means your FDS and FDP, both are gone. Your flexor digitorum superficialis is gone, your flexor digitorum profundus is gone. But the important point is, flexor digitorum profundus, only lateral half is gone. Medial half is still working. So out of all the flexors of the finger, in case of higher injury of median nerve, out of all the flexors of the finger, only medial side flexor digitorum profundus is working. Rest all the flexors are gone. All FDS and FDP of the lateral side is gone. So when I try to make a fist, I can just make a fist on the medial side using the ulnar side fingers like the third and fourth digit or maybe the second digit also. And that way, index finger will not flex at all. Why index finger will not flex? Because FDS is gone and the lateral half of FDP is also gone. So for the index finger, neither you have FDS working nor you have FDP working. So you cannot flex the index finger at all, and that is called as a pointing index finger. while trying to make a fist, if you see a patient is having a pointing index finger, that means it is the higher injury of the median nerve here. Patient will not come to you with the pointing index finger. You have to ask him to make a fist, and while making a fist, you will see that there is a pointing index finger. So that is an indication of what injury? Higher injury. If the injury is lower, let's say at case B here, in this case, FDS is working, FDP is working. Now you have a ape thumb deformity, okay, but you can make a fist because your FDS and FDP is working. So asking the patient to make a fist, and patient can make a fist here. No problem with that. One simple thing, guys, we just have to do a sensory test. If the sensation on the palm is working and the sensation on the finger is lost, it is definitely the lower injury. It's a carpal tunnel syndrome. Because if the nerve is compressed here, we know that palmar cutaneous branch will be spared, and palmar cutaneous branch supplies the skin of the palm. So in case of carpal tunnel syndrome, you have a sensory sensation intact on the palm but lost on the fingers. So that tells you it is what injury? It is a lower injury, or it is a carpal tunnel syndrome. I'll write all these, I'm just telling you first here. That is a carpal tunnel syndrome. And finally, the case C, guys. What happens in case C? If the injuries to, let's say only injuries to anterior interrocious nerve, only anterior interrocious nerve is injured. Because of injury to anterior interrocious nerve, I want to take your attention to these two muscles here. Flexor digitorum lateral half of flexor digitorum profundus is not working. That means index finger FDP is not working. And FPL, flexor pollicis longus, is not working. That means your long flexor of thumb is also not working. So when your patient cannot flex the distal interphalangeal joint of the finger or the interphalangeal joint of thumb, you ask him to make a OK sign. When you ask your patient to make a OK sign, now generally the normal OK is circular OK like this, because I can flex my interphalangeal joint here. Just look at against the black background. I can flex this interphalangeal joint here, and I can flex this interphalangeal joint of thumb also, and that's a circular OK here. But imagine if my FDP is not working and my FPL is not working, I cannot flex these joints, and these joints will be straight like this. So I'll make a OK like this. That is like a collapsed OK. It's like a collapsed OK. It's not a circular OK, it's more of a collapsed OK. And this collapsed OK sign is a sign of which nerve injury? The anterior interrocious nerve injury. Your long flexors are not working, and that's why you cannot flex them, and you cannot make a circular OK. Your OK will be more like a collapsed OK sign, is a sign for anterior interrocious nerve injury. So guys, let me just write that. What I'm saying is, in case of higher injury, the case A is a higher injury here. Now this higher injury could be because of any reason. There could be a supracondylar fracture, the pronator teres syndrome, the cubital fossa syndrome, whatever the reason is, guys. If the median nerve is compressed higher or injured in the higher part here. So one thing which we said will be there in the median nerve injury always is ape thumb deformity. Ape thumb deformity is there. Ape thumb deformity is there. And the important thing is that FDS and lateral half of FDP is involved. In the higher injury, FDS and lateral half of FDP is involved, so there will be pointing index finger. There will be pointing index finger, but important thing is while making fist. While making fist, guys. Pointing index finger while making a fist. Then you will see a pointing index finger here. While making a fist, you can see a pointing index finger. And there will be sensory loss on the entire hand and the on the palm and the skin, so nothing to differentiate there. So important thing is that there is a ape thumb deformity and there is a pointing index finger along with that. While making a fist, it tells you it's a higher injury here. Case B is a lower injury, or you can simply say carpal tunnel syndrome. Now, in case of carpal tunnel syndrome, CTS, the carpal tunnel syndrome or the lower injury, what happens is, once again, there will be ape thumb deformity because opponent's pollicis is not working still. So, ape thumb deformity is inevitable, that will be there. This time, there is no pointing index finger. There is no pointing index finger this time because FDS and FDP are working. But the important thing is that sensory loss is seen only on fingers, lateral 3.5 obviously, only on fingers and not on palm. And why so? Why so? As palmar cutaneous branch is spared. As palmar cutaneous branch is spared, it is passing superficial to the flexor retinaculum, so it is spared, and that's why there will be no sensory loss on the palm. Finger pe there will be sensory loss for sure. So ape thumb deformity, no pointing index finger, you can make a fist, no problem with that, but the sensory test will help you here. The sensation on the palm is intact and lost on the digits. And then we have this case C, that is anterior interrocious nerve injury. In case of anterior interrocious nerve injury, remember, the patient is having inability to flex the distal interphalangeal joint of index finger and interphalangeal joint of thumb, because of which there will be collapsed OK sign. You cannot make a OK sign circular OK, that will be a collapsed kind of OK sign, and that is seen in what nerve injury? That is an anterior interrocious nerve injury. That is seen in the anterior interrocious nerve injury. So higher injury, the lower injury, and then we have this anterior interrocious nerve injury, in which you will see there is an inability to flex the distal interphalangeal joint of the index finger and the interphalangeal joint of thumb, that is not allowing you to make a circular OK. Okay. See, in the ulnar nerve, what you see, guys, first of all, the root value of the ulnar nerve is not the entire brachial plexus, it is C7, C8 and T1. C7, C8 and T1. So it's a C7, C8 and T1 is the root value for the ulnar nerve. We all know that ulnar nerve, the main thing is it passes behind medial epicondyle. You can see that that's a medial epicondyle, and the nerve is passing behind the medial epicondyle. Once the nerve crosses the medial epicondyle in the forearm, it enters the anterior compartment of forearm by passing and supplying this muscle, and that muscle is flexor carpi ulnaris. Flexor carpi ulnaris, guys. Ulnar nerve is going through the flexor carpi ulnaris. It is supplying it also, and then that's a muscle. That's a flexor carpi ulnaris. Ulnar nerve is also giving off a branch to the flexor digitorum profundus, and that to the medial half of flexor digitorum profundus. The medial half. It supplies the medial half of flexor digitorum profundus. Medial half of flexor digitorum profundus. So only 1.5 muscle I can say in the forearm are supplied by the ulnar nerve. One is flexor carpi ulnaris and the flexor digitorum profundus medial half. Lateral half was by the ulnar nerve. That's it. 1.5 muscle. Ulnar nerve is passing superficial to flexor retinaculum. We already discussed that. It is passing superficial to flexor retinaculum, and then it goes through a canal, and this canal is called as a Guyon's canal. Guys, this canal is called as a Guyon's canal. Guyon's canal. So ulnar nerve is passing through this Guyon's canal, and once the ulnar nerve crosses the Guyon's canal, it is giving off two branches. Now this is a superficial branch. Just pay attention. This is SB. I'm writing SB is for the superficial branch, and this main continuation is a deep branch. So these are the two branches of the ulnar nerve. One is a superficial branch and the deep branch here. The superficial branch of ulnar nerve, apart from supplying the skin, you can see it is supplying the 1.5 skin. That's the only part left. It is supplying the 1.5 of the hand on the palmar aspect as well as dorsal aspect. Apart from supplying the skin, the superficial branch supplies just one muscle, and I hope you remember that muscle, guys. The only subcutaneous muscle that we have, and that muscle is palmaris brevis. Palmaris brevis, the only muscle to be supplied by the superficial branch is palmaris brevis, and it's the deep branch of the ulnar nerve which is going to supply the major muscles of the hand. Like it supplies remaining all hypothenars, it supplies all interrotii. If you remember, all interrotii are supplied by the ulnar nerve, palmar interrotii, dorsal interrotii. It supplies third and fourth lumbrical, L3 and L4. And then we know ulnar nerve is ending by supplying what muscle? Adductor pollicis. One of the thenar muscle, the last muscle to be supplied by ulnar nerve, that is adductor pollicis. Let me just use a different color to show that. So that's a deep branch of ulnar nerve, and this deep branch of ulnar nerve is supplying the hypothenars. It supplies all interrotii, it supplies third and fourth lumbrical, and it also supplies or ends by supplying the adductor pollicis. Ends by supplying the adductor pollicis. Now, see, what is the question in the ulnar nerve? Guys, see, question in the ulnar nerve is not challenging. Ulnar nerve injury, obviously, all the intrinsic muscle will be gone. So, the challenging question in the ulnar nerve is not about what will the feature will be. We know that ulnar nerve injury leads to the ulnar claw hand. If the intrinsic muscle will be involved, whether it is higher injury, whether it is lower injury, obviously there will be claw hand in the ulnar nerve here. The important thing in the ulnar nerve injury is the ulnar paradox. Paradox, opposite. In case of higher ulnar nerve injury, you have a less severe claw hand. And in case of lower ulnar nerve injury, we have more severe claw hand, and the reason behind that is this muscle. See, if it is a lower injury, if the nerve is injured at the level of Guyon's canal or anywhere at the retinoculum, that means at this point if the nerve is injured, then intrinsic muscles of hand are gone, so there is a claw hand is there. And imagine, because the injury is here, which muscle is still working? FDP is working. Imagine your FDP is working. You already have a claw hand and your FDP is working, so you have more flexion at the interphalangeal joint, and that will make it look like a more severe claw hand. But imagine if the injury is higher, if the nerve is injured at the medial epicondyle, fracture of the medial epicondyle. If the nerve is injured at the medial epicondyle, again you have a claw hand because the intrinsic muscles are gone. But this time which muscle is also gone? The FDP muscle is gone, and because FDP muscle is not working, so there will be no flexion at the distal interphalangeal joint, which will keep these fingers a little straight, and that will look like a less severe claw hand. That is called as ulnar paradox. In higher injury, we have a less severe claw hand, and in the lower injury, we have a more severe claw hand, and the responsible muscle for that is FDP. If your FDP is working, that will cause more flexion at the interphalangeal joint. If your FDP is not working, then it will cause less. If your FDP is not working, then obviously there will be extension at the interphalangeal joint, and that will look like a less severe claw hand, and that is nothing but the ulnar paradox. So in the higher injury, there will be less prominent, or again less severe claw hand. Less prominent or less severe claw hand as FDP is also involved. As FDP is also involved, therefore distal interphalangeal joints cannot flex. The distal interphalangeal joints cannot flex, they are extended here. If your distal interphalangeal joints are extended, imagine like this, and if you make a claw hand, it looks like a less severe claw hand. But if the injury is lower, FDP is working, then your distal interphalangeal joint will be flexed, and that looks like a more severe claw hand, and that is what you call as ulnar paradox. That is called as the ulnar paradox.